This is a routine phaco emulsification using a 2.0 keratoon done in a grade maybe 3 plus. I have done my incision, done both my side ports, stained the capsule and expel the stain as well as the air with 2% HPMC. And I'm going ahead with my capsular excess, which I almost exclusively do with the bent 26 gauge. I very rarely initiate or complete my rexus with the forceps, but you could do that as well. There, that's done. It's a pretty good rexus. Then go ahead and do my hydrodissection. I could see the wave going across, decompress, try to rotate the nucleus with the cannula itself. Just making sure hydrodissecting in another area. Put in some HPMC and take my 2.2 phaco tip and my sharp chopper in my left hand. So in this case, I just impale the nucleus. I am going in with I think 60% phaco power, 400 ml 400 millimeters of mercury vacuum, 40 ml flow rate, and at this point in time it is in continuous mode. So that first chop was good, just aspirating some more of the superficial cortex. Go in again, engage the nucleus in the mid periphery with my chopper, go towards the chopper, and as you approach, laterally separate. Now the movement of your chopper and your phaco tip, see, when the phaco starts engaging, it's actually both are towards each other, so you're basically crushing the nucleus and fracturing it. And the lateral separation is extremely important. Watch your lateral separation, because finally the idea is to not only crack it, but you have to break the central spine. You cannot be left with that central spine, because then it becomes very difficult to take out these pieces. They just sort of retract every time you try to hold on to them. They just do not come out of this bowl. Since this cataract is actually a grade 4, it's pretty hard cataract, it's not that soft, I decided to make more pieces. And there, that's 6 pieces, that should be enough. Yeah, I start taking out. Always try to get the segment from the apex, or one of the corners at least. Keep picking up one by one. I always stay in the safe zone, I hardly move away from it. Having said that, sometimes I do move. That's a pretty large piece. Just moving the epinucleus away so that I can see what I am phacoing. I've actually got the lower piece. Unfortunately, I have made it a little uncomfortable for the patient by not considering his head position, and yeah, it's a little difficult for him to keep that position for this prolonged periods of time. difficult for all of us, but at the same time I do not want to hurry this surgery. This is a 2.2. It always takes a little more time than 2.8, especially in the harder cataracts. The softer cataracts you can do it pretty fast, but the harder cataracts do take time with smaller tips. You cannot hurry them. And there, that's done. Everything done in the safe area, everything done far away from the endothelium. And then take my, seem to be having a little bit of a surge problem, probably my, there are several reasons for this. One is either the fluid is getting over, but then that would collapse completely. Maybe there's a kink in your aspiration tube, or maybe there was some air in that, and in your IV line itself, and now that's much better. Just cleaning up the posterior capsule. Once I've done that, I put in some HPMC and use the wound assisted method to put in this single piece hydrophobic IO. Many times I increase the incision, but you can do a wound assisted, little more difficult. Sometimes the lens can get stuck if you are unlucky or you haven't done it right. There's no thing as unlucky. And once I have done that, I go ahead, aspirate all the HPMC from within the chamber. And following this, I usually put in my intracameral antibiotic. I hydrate my paracentesis definitely, perform the bounce test, and close shop. Thank you so much for watching.